Hello, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I'm very pleased to welcome you all to today's breakout session on Waldenstrom's macroglobulinemia, also known as WM. So, just before we start, I wanted to go through a few housekeeping items. This Zoom software does not allow you to access chat features or turn on your microphone. If you have a question, this session will be followed up by a live Q&A session, so please keep your questions in mind and please be sure to attend the indolent non-Hodgkin lymphomas Q&A afterwards. So to introduce our speaker, today we have here Dr. Anthea Peters, who is a hematologist based at the Cross Cancer Institute in Edmonton, Alberta, and is an associate professor in the Department of Oncology at the University of Alberta. She completed her MD at the University of Saskatchewan, internal medicine residency training at the University of Alberta, and hematology training, as well as a lymphoma fellowship at the University of Calgary. Her clinical and research interests are centered around lymphoma and chronic lymphocytic leukemia, or CLL, with a special interest in post-transplant lymphoproliferative disorders. So thank you, Dr. Peters, for joining us today, and you can get started as soon as you're ready.
Okay, thank you so much for the nice introduction. I'm really excited to present today on Waldenstrom's macroglobulinemia. I'll start by just giving you a few disclosures from advisory boards I've attended, as well as some research funding. And I will be talking about some off-label treatments as well. So just to start off, I thought I would give you a little bit of a view into my practice, which is encompassing all of northern Alberta. So in the center here, we have Edmonton, which has a population of almost 1.5 million. And our catchment area at the Cross Cancer Institute is basically everything north of Red Deer. And so we see patients from a very wide geographic distribution, which does present many challenges for patients in particular because they do have to travel great distances. Um, so that's just a bit of a view into my world. Um, Now, for this talk, I wanted to cover basically what is Waldenstrom's macroglobulinemia. I'm going to cover how we treat Waldenstrom's. I'll often sort of abbreviate by just saying Waldenstrom's. And then I'll talk at the end about some new developments in treatment of this cancer. And I have to admit that this is always a bit challenging to speak with a patient audience, although I find it the most fulfilling. And I really look forward to the live Q&A session. But I think it's hard to gauge people's understanding of the biology and the background. So I hope I don't lose anybody. I'm going to start off by just describing the basics of the lymphoid system in the body. So this system, you probably don't even know you have. And it is basically a large part of the immune system that fights infection. And so we have in the middle the cells of the lymphoid system called lymphocytes, and they travel. They don't stick to one organ or one area of the body, they travel all around, which is a major feature of why we find lymphomas uh, often spread to other areas of the body at diagnosis. So the places that these cells travel include the bone marrow on the left here and the blood on the top. They also travel through the spleen. The spleen is an organ that sits right beside the stomach. It's kind of under the ribs on the left side. And lymph nodes, which are little tiny structures that are found throughout the body. Um, and then on the right here, we sort of have the other category. And so that's to tell you that there's lymphoid cells traveling to basically any part of the body. But there's also little concentrations, for example, in the small bowel. Um, and what happens when one of these lymphocytes becomes a cancer cell, it flows through this system as well. So what we do find is that these abnormal lymphocytes, which lose the ability to stop growing, they start to enlarge lymph nodes. So you may find on scans some lymph nodes enlarged. They can occupy the spleen and make the spleen enlarge. And when they occupy the bone marrow, they sort of collect in the bone marrow, and what happens is that they crowd out the normal cells. I'm just going to flip to the next slide to show you a bit in more detail. So this is a picture of the bone marrow, and this is actually the factory of your normal blood cells. So these start out as stem cells, and then they become red blood cells, white blood cells, and that's where your lymphocytes are categorized, and then finally platelets. So all of these cells come from the bone marrow. And what happens when you get an abnormal B cell that becomes a lymphoma cell? So that's sort of pictured here with the dark blobby cell. You know, you go from having a bone marrow with a large variety of healthy cells um, like this to all of a sudden having um, more of these abnormal B cells occupying the space, and the red blood cells, platelets, those cells start to get crowded out. And when we measure them in the blood, the number of those cells becomes low. So that just gives you an idea of what happens when a lymphoma occurs. And I haven't gotten yet into Waldenstrom specifically. I'm just sort of trying to describe the background of lymphoma. So on this slide, I'll go over how patients discover they have lymphoma. Sometimes people are completely asymptomatic and really sort of go to the doctor for a totally different reason. And that can be quite common in particular types of lymphoma. However, sometimes people have complaints, certain symptoms that make doctors suspicious for possible lymphoma. So one of those is unexplained weight loss. Another is night sweats. Um, Sometimes doctors order imaging or scans that show enlarged lymph nodes or enlarged spleen. And those are two areas that I mentioned earlier, areas of the body that can make us suspicious that there is a lymphoma going on. And then thirdly, there can be lab work abnormalities, such as low hemoglobin, that's a measure of red blood cell count, and low platelets. And that goes back to the explanation earlier regarding the crowding of the bone marrow from lymphoma cells. Um, and so if there is a suspicion of a diagnosis of lymphoma, what we need to do is prove that and then go forward with a biopsy. There could be a biopsy of the lymph node or a bone marrow biopsy. And then that biopsy tissue gets examined under the microscope, and a pathologist would then tell us what type of lymphoma is contained within that structure. And there is a large list. I haven't listed an exhaustive list here. There's just some categories. So I've mentioned non-Hodgkin lymphoma as opposed to Hodgkin lymphoma. So those are the two big categories at the top. Non-Hodgkin lymphoma is then divided into B cell versus T cell. And it's also divided into clinical behavior. So this indolent lymphoma category is describing the behavior of lymphoma, and that's in contrast to aggressive lymphomas or very aggressive lymphomas. So I've listed two examples of indolent lymphoma. One is follicular lymphoma, that's the most common in this category, and a less common type, which has two names, one lymphoplasmacytic lymphoma, um, and if it's accompanied by a particular protein that I'll describe soon, it's called Waldenstrom's macroglobulinemia. And a couple more slides just to describe the term indolent. So I think it's important to sort of appreciate that when we talk later about the treatment. So the word indolent, again, it's describing the clinical behavior. These two columns describe some of the features and try to contrast and compare. So with indolent lymphomas, we see that the cells divide slowly and the tumors or lymph nodes grow slowly. And when I say slowly, sometimes, we happen to do scans once a year, and the usual course is we see growth about 0.5 or 1 centimeter per year. So it is extremely slow. Comparatively, aggressive lymphomas do divide very quickly and the tumors grow quickly. Indolent lymphoma patients tend to have fewer systemic symptoms, which is the opposite of patients with aggressive lymphoma, where they more often have those B symptoms, we call them, fever, weight loss, and night sweats. Now, importantly, we also know that indolent lymphomas, partly because they grow so slowly, cannot be cured by treatment. They they respond very well to treatment and go into remission with treatment, but they actually eventually do grow back again. And that is different from some aggressive lymphomas, which can be completely cured with treatment. And so because patients tend to not have a great deal of symptoms, these lymphomas tend to grow slowly, and because we cannot actually cure them, there isn't any advantage to starting treatment right away. We can actually watch patients, and sometimes for their entire remaining years, without instituting treatment. So just the fact that you have lymphoma does not necessarily mean that you need treatment right away. That cannot be said for aggressive lymphomas. These aggressive lymphomas can be cured with treatment, and patients do get very sick. So urgent treatment does make a large difference to their outcome. All right, so now I just want to focus specifically on Waldenstrom's. And some of this material I found from the International Waldenstrom's Macroglobulinemia Foundation, which is a website that has a lot of good information, as well as some information from Lymphoma Canada and some other support sites. So specifically with Waldenstrom's, we see that it's a very rare type of blood cancer. There's an estimated 1,500 to 3,000 cases per year in Europe and the US, and even fewer in Canada. We've already talked about some of this. So again, we see they have healthy lymphocytes that transform into abnormal white blood cells and then build up in the bone marrow. And the specific cell in the case of Waldenstrom's is called a lymphoplasmacytic cell. And these cells actually are producers of a protein, which is a type of antibody called IgM, and it's shown here. So it's a pretty big molecule with 5 receptors on the outside, and can be quite sort of um, big and sticky. And um, one of the major features of Waldenstrom's is that, not only do we have this buildup of cancerous white blood cells, but we also have a buildup of this IgM protein in the blood. And that protein can actually thicken the blood and um, cause issues for the patient, specifically something called hyperviscosity. So we'll get to that in a moment. This is just a picture of the blood in a tube, and it's actually spun down with a centrifuge. And so you can see there's a layer of red blood cells and then a thin layer of white blood cells and platelets called the buffy coat. And then on top, there's the majority of the blood composition, which is the plasma. And that's where the IgM protein would be found, is in that yellow liquid called plasma. And in a Waldenstrom's patient, that component of the blood is what becomes thickened due to that IgM protein. This is just another depiction of antibodies. So again, one of the antibody classes is called IgM. So it's not an abnormal protein on its own. It is a normal part of our immune system. It's just that in Waldenstrom's, it is overproduced. And it happens to be one of the biggest antibodies and stickiest because of all these receptors on the outside that can lead to hyperviscosity. Okay, so in order to diagnose, I mentioned earlier that we need a biopsy to diagnose any type of lymphoma. Well, for this type, we tend to see most commonly involvement of the lymphoma in the bone marrow. So we tend to need a bone marrow biopsy to check for these abnormal cells. And then in addition to that, we do a blood test to look for that IgM protein. And there's actually a test just looking at the amount of IgM protein. And also what they're depicting here is something called a serum protein electrophoresis, which looks at whether or not the IgM protein is what we call clonal. So in normal blood, in blue, we just see this normal pattern of protein. And in yellow, they're depicting that patients with Waldenstrom's have this peak, which indicates an IgM peak. It's a peak because it's a clonal protein. It's a clonal antibody. If it were not clonal, it would be spread across this electrophoresis. So the symptoms of Waldenstrom actually, I've discussed a little bit already, but again, some people are completely asymptomatic, whereas others do have symptoms, and these symptoms can be caused by the cancer cells themselves and or the protein, that IgM protein that we discussed. So this graph just sort of breaks down these symptoms a little bit. So the top row, so here, fatigue, tingling, numbness. They're talking about numbness in the fingers and toes and tingling in the fingers and toes, as well as just muscle weakness. This is usually related to the IgM protein. As well, these symptoms like bleeding in the eye, and by that we actually mean bleeding in the retina, um, rarely bleeding in the brain, or there could be bleeding such as nosebleeds, and bruising. This is also caused by this excess of IgM protein. It's a bit complex, but it's actually due to that thickening of the blood. Um, and then on the bottom row, there's some symptoms that are more related to the abnormal cells themselves. So again, referring back to my general slide about lymphoma, we see enlarged spleen or lymph nodes. That's caused by the buildup of these abnormal white blood cells within those structures. And then we see that people can have fatigue from anemia. So that's low red blood cells, and that's usually caused by this crowding in the bone marrow. All right. So next, I just wanted to mention stage. Many people ask about stage, and I think it's, definitely relevant. And I find often people are surprised by my answer. Stage in lymphoma is usually done by a system called the Ann Arbor staging system. Um, and that describes where areas of involvement are located above and below the diaphragm. Um, but it actually gives you a stage of 4 if you have bone marrow involvement. And as I mentioned earlier, the vast majority of people with this particular kind of lymphoma and many other types of lymphoma have bone marrow involvement. Um, it's not a bad thing. It doesn't mean that, you're in a bad situation or an unsolvable situation. This is just the nature of the disease. And so, sometimes I wish we would not talk about stage in particular types of lymphoma. It does increase anxiety. But I just want to reassure you that it is normal and it would be extremely rare to not be stage 4. So we do, talk about stage, but we don't put a lot of weight in stage. It doesn't actually change what we do for treatment, or even it doesn't change prognosis. And I'll talk about that on the next slide. And I'll just mention too that because of that Ann Arbor staging system, we do use body imaging for stage. So generally CT scan for this and other indolent lymphomas, just to get a sense of where the enlarged lymph nodes are located. So this is a lot of writing, and I don't need you to get into the details here, but this is a description of how we determine patients' prognosis. And the word prognosis just means the estimated predicted outcome of patients. Generally, we do it at the time of diagnosis. This is a scoring system that's been developed and uses data from many, many patients over the years, described in different clinical trials. Um, and most of the data is actually a bit old, based on patients that had been treated only with chemotherapy. But what they describe here is that there's 5 features that would determine risk. Um, and so one is age over 65, which is, describes most patients with Waldenstrom's. Hemoglobin less than 115, the way that we would describe it in Canada, 11.5 in the American system, platelet count of 100 or less. And then there's 2 blood tests. So one is called beta 2 microglobulin, And if that's greater than 3, and then back to that serum protein electrophoresis that we talked about, if we do find a monoclonal protein, in this case would be IgM, and the amount would be greater than 70 grams per liter. And then for this system, you get 1 point except for age, and then they categorize patients into 3 categories. And again, it's just to predict. It doesn't have any bearing on how we treat patients, um, and it is in fact a little bit outdated. So it just gives you an idea. Um, One thing I wanted to mention and found quite reassuring myself is that uh, patients actually tend to do very well with Waldenstrom's in general, and um, their prognosis is very close to their age-matched peers in most categories. So this is a British Journal of Hematology publication where they looked at only patients with Waldenstrom's, and they broke them down into people less than 65 years at diagnosis, 65 to 74 years, and then 75 or greater. And they determined the causes of death. Red being lymphoma, blue being non-cancer conditions, and green being non-lymphoma cancers. And what they found was that the patients over 70 or over, um, actually died of other conditions more commonly than lymphoma or other cancers. So if you look at these curves here, the top curve is blue, and that's non-cancer conditions. And as well, even age 65 to 74 patients tended to die of lymphoma and non-lymphoma, or sorry, non-cancer conditions at the same rate. The only category where this was not true was in the patients less than 65, where we actually did see that lymphoma was the cause of death in the majority. So I think we can sort of say that, the patients under 65 are the ones that are going to potentially have a limited lifespan due to lymphoma. Now, I wanted to touch on this really interesting finding. So, in about 2011, Dr. Treon, I believe he's from Dana-Farber, had discovered that there's a mutation called MYD88 on chromosome 3, and another mutation called CXCR4 on chromosome 2. And as it turns out, 95% of patients with Waldenstrom's have this MYD88 mutation. And keep in mind, this is not a mutation that's in your genes that you pass on to your children. It's in the cancer cells themselves. Okay. So this is actually high enough where we would say that this mutation could be the cause or the inciting kind of cancer-causing mutation, which is very, very interesting because that presents opportunity to target for treatment. Now, the same cannot be said for CXCR4 because it's only about 30% of patients that have that mutation, so it couldn't have been the cause, but is common enough that, it certainly provides some interesting information, and you'll see a little bit later that it does have relevance to treatment. So I'm going to focus now on treatment and how we treat Waldenstrom's and when we treat Waldenstrom's. And so that's the first question. When do patients need treatment? Because in the near the beginning of the talk, I mentioned that indolent lymphoma patients don't benefit from treatment um, unless they have a clinical need. Because again, these are not curable cancers. So the treatments are very effective, but they don't cure. Um, and there's just no advantage to starting early. However, there are certainly people that need treatment, and we will focus the rest of the talk on treatment. So the first issue is hyperviscosity. I talked a bit about the thickening of the blood due to the IgM monoclonal protein, and this is, a medical emergency. So even if your doctor is planning to start treatment in the near future, that treatment is going to decrease the IgM protein, but it needs to be done very quickly. And oftentimes the treatment isn't going to do so fast enough. So we recommend that people do something called plasmapheresis. And I'm actually going to flip forward few slides to plasmapheresis because I just wanted to visually explain it. So you actually get a sort of large IV placed, and the blood is, not all the blood at the same time, but some of the blood is taken out, run through an apheresis machine with some anticoagulant to make sure it doesn't clot. And then the machine does some separating of the blood and extracts the plasma. And then we add plasma back or albumin back, and then the blood circulates back to the patient. So in this way, we sort of remove some plasma that's too thick due to the IgM protein and give back some plasma that is without the protein. So this is how we deal with emergencies due to IgM protein. And these symptoms, as I mentioned earlier, they can be bleeding, retinal hemorrhage, headache, vision changes. Those need to be dealt with urgently. So other symptoms or complications, these are the criteria for starting treatment. If patients have um, uh, any one of these, then it may be time to start. So this first category is again when the bone marrow becomes full of lymphoma cells. We see low red blood cells, low platelets. We may see symptoms from an enlarged spleen. So we call this early satiety, and that just means that you're hungry, but when you try to eat, the stomach becomes full too quickly. There can be discomfort from enlarged lymph nodes. There can be fever, weight loss, night sweats. And then there's actually a list of other IgM related complications such as cold agglutinin disease and cryoglobulins and autoimmune issues. So, you know, with your doctor, your hematologist, or oncologist, um, these are the issues that need to be taken into account when deciding when it's the right time. There is, of course, a time period usually of watch and wait. And I just wanted to mention that people tend to become very anxious during this period. That is completely normal. It's hard to be diagnosed with cancer and then not treated. I know the Lymphoma Canada website has some excellent resources on watch and wait. that I always direct my patients to. And I just wanted to mention, I should have put a reference in for this, but we have a wonderful nurse practitioner who talks about CLL in a similar way and says, well, instead of watching and waiting, which kind of implies, the dread and the waiting um, period, she flips it around and says, well, instead of that, let's just monitor and move on, which implies a bit more of an active and uh, vigilant process rather than the passive dread of watching and waiting, which I kind of like. So, and I just wanted to flash this up as well. This is just a risk calculator that's on the website awmrisk.com. This is through the Dana-Farber. Um, and it's just simply a way that you can estimate when you would potentially need treatment for Waldenstrom um, based on some blood work. And then this is the percent infiltration in the bone marrow by the lymphoma cells. So you would have to have had a bone marrow, not a lymph node biopsy, and would have to get all these results to calculate a risk score. And of course, it's all statistics, so it can't be completely accurate, but this gives you a sort of an estimate of the time you're going to need to wait, which can be quite um, handy and kind of help plan life in some ways. Um, and so getting on to actually what types of treatment in the last part. We did talk about hyperviscosity. This flow chart was adapted from the British Journal of Hematology guidelines for treating Waldenstrom. We talked about urgent plasmapheresis. And then if there is an indication for treatment otherwise, this guideline lists the different types of treatment recommended. So this is the main category of first line treatment that's recommended, which is chemotherapy, CD20 antibody, and sometimes steroid. So generally speaking, in Canada, we would tend to use rituximab and bendamustine as first line treatment. There is a group of patients that are maybe a bit more frail or maybe have more of an autoimmune issue that you would want to use rituximab, cyclophosphamide, and dexamethasone instead. And then there is also a drug called bortezomib, which is used in multiple myeloma that has shown very good outcomes in Waldenstrom's that you can try. The only warning, of course, is that bortezomib can cause significant neuropathy. So in somebody that has neuropathy from Waldenstrom's, you would certainly want to avoid that. And then there's also a finding that rituximab can actually flare IgM symptoms. So if somebody had hyperviscosity or some symptoms related to IgM, they may worsen initially. This very busy slide, I just wanted to show quickly to talk about the next group of drugs, which is BTKI or Bruton's tyrosine kinase inhibitor. And that is, if you look here at these blocks showing a cell signaling pathway on a B cell, this is the B cell receptor. And then this blue block here is called the BTK. So it's just an enzyme. It's a tyrosine kinase or an enzyme. And this group of drugs blocks this particular enzyme. So we call this type of drug a targeted drug. And so it turns out that the Waldenstrom's responds very well to this class of drugs. So ibrutinib was the first one tested. So they did a clinical trial in previously treated Waldenstrom's, um, again with Dr. Treon, and found that in 90% of patients, it decreased the IgM monoclonal protein and improved hemoglobin in about 90%. And then he also found that the highest response was in the patients that have this MYD88 mutation, but did not have the CXCR4 mutation. And additionally, it was very well tolerated. Only 20% had low neutrophils, whereas if you look at chemotherapy trials, it's often more like 80% or higher. Only 8% had pneumonia. But there was some issue with bleeding and something called atrial fibrillation, which is um, an abnormal heart rhythm. And that turns out to be very problematic because you need to um, start anticoagulation to prevent stroke. Now, we've since then been introduced to a second generation of these BTKIs called zanubrutinib, and there's another called acalabrutinib. They managed to randomize 201 patients to either one of these drugs for Waldenstrom patients, which had never had any treatment before. They found a very similar effectiveness of these two drugs, but the zanubrutinib is actually less toxic. So specifically, atrial fibrillation and bleeding occurred less often in these patients. So in our clinics, um, we have shifted away from ibrutinib and solely use zanubrutinib, or if we had it approved, acalabrutinib, because either of those drugs would be expected to be better tolerated. So just as a summary, this whole class of drugs is very effective in Waldenstrom's. They're oral as well, so they're very convenient. The major downside is that they're all taken indefinitely, and people tend to not like to be on drugs indefinitely. We have improved toxicity for second generation. There was a clinical trial called the Innovate trial, which paired it up with rituximab. It's unclear if that actually adds any benefit. Um, and so in Canada, because of the public payer system, we tend to want to reserve these for relapsed Waldenstrom. That way you have a shorter course of chemotherapy at the beginning, you get a treatment break, and then when the lymphoma relapses, then you would go on BTKI. And then this is the final drug that I just wanted to mention. This is called venetoclax. So this is a BCL2 inhibitor, another oral agent, um, but very effective as a single agent. So about 20% have a durable response, and it's used more in a time-limited fashion. So in these trials, they used it for 2 years and then stopped. Um, so there is promise for people that have already had ibrutinib now or zanubrutinib. Now, the more recent trial that was just reported in Blood had combined venetoclax with ibrutinib in the hopes that they could do a 2-year course and then stop. Very good complete response rates of 40%. Unfortunately, the trial was stopped early due to 2 sudden cardiac deaths due to ventricular arrhythmias. So we're not sure how that will impact its approval, but it's certainly very concerning. And then down the road, we may be looking at some better access to other drugs. We have been participating in a Canadian trial called BROM, which uses bendamustine rituximab plus acalabrutinib. And then I'm aware of some other clinical trials using pembrolizumab, pirtobrutinib, and another drug class called a BTK degrader. So these trials are in progress. And then certainly CAR T cell therapy, which is being used in other types of B cell lymphoma, may be a possibility down the road for Waldenstrom's. So there is potential for further development in this very interesting lymphoma. I just wanted to finally say a few words about infection. This group of patients certainly does have a higher risk of infections. All of these treatments, unfortunately, make that risk worse. And so it does remain important to defend yourself against infections. And the best way to do that is with vaccines. Um, so right now, influenza and COVID vaccines are just becoming available in your community. So you should seek those out both for yourself and for caregivers. The Shingrix vaccine for shingles and the pneumococcal vaccine is also a good idea to get. And just to mention some websites and support groups that I found really helpful for developing this talk. And that's all I have. Thank you so much for your attention.
Thank you, Dr. Peters, for that very informative presentation. For the audience to have your questions addressed, please be sure to attend the Indolent Non-Hodgkin's Lymphoma Q&A, which will begin in a few minutes. Thank you and see you there.